Here's our game plan. 1. The Hinchey classification system. 2. Stage-by-stage management. 3. A key clinical pearl. 4. The classic exam trap. And 5. A quick recall test. Let's get right into it.
Section 1. The Hinchey classification system, mapping the pathology. So imagine a micro-perforation in the colon. The pathology kind of progressively worsens from there. At step 1, your body actually manages to wall it off, creating this contained, localized inflammation or abscess right next to the colon. But if it escapes that containment, step 2 expands into a distant abscess. Maybe it settles down in the pelvis or the retroperitoneum. Then by step 3, containment is just completely lost, dumping purulent fluid, literally pus, throughout the entire peritoneum. And finally, step 4. This is a catastrophic, generalized emergency with frank fecal contamination spreading everywhere in the abdomen. So you can see it's a straight line from a local problem to a massive systemic insult.
Now this table right here, this is basically your mental flashcard. You really want to lock this matrix in. Stage 1 is your pericolic abscess or phlegmon. Stage 2 is that distant pelvic or retroperitoneal abscess we just talked about. Stage 3 jumps all the way up to generalized purulent peritonitis. And stage 4, the absolute most severe, is generalized fecal peritonitis. Just having this simple binary mapped out in your head is going to make answering this complex clinical vignettes almost instantaneous for you.
All right, moving on to Section 2, stage-by-stage management intervening based on severity. So for the localized and distant abscesses of stages 1 and 2, our absolute first line of defense is IV antibiotics, bowel rest, and, just solid supportive care. If it's a small microabscess, conservative management often does the trick. But say you've got a larger or non-resolving stage 1 pericolic abscess, or maybe a stage 2 distant abscess that's anatomically accessible, that's when the standard of care escalates to image-guided percutaneous drainage. Basically, we want an interventional radiologist to get a drain in there and clear that infection without having to actually open up the abdomen.
But wait, stage 2 isn't always managed non-operatively. This is exactly where your clinical judgment has to kick in. Surgical intervention is absolutely mandated if, say, drainage is anatomically impossible, or if the patient's sepsis just persists despite all your interventions. Also, if they rapidly deteriorate, or if conservative management simply fails. Look, if tubes and IV antibiotics aren't turning the tide, you're going to the OR. Simple as that.
Now, moving to stage 3, the entire paradigm completely shifts. With generalized purulent peritonitis, you have to pivot aggressively to urgent resuscitation and operative source control. The surgical options here depend heavily on how stable the patient is. Your primary path is usually a resection of the diseased colon with a primary anastomosis, and often you'll pair that with a temporary diverting stoma just to protect that healing connection. But listen, for highly unstable, high-risk patients who physiologically just cannot tolerate an anastomosis, we rely on the classic Hartmann's procedure. You know the drill, an end colostomy and a rectal pouch. You take out the bad part, bring the healthy bowel up to the skin, and you let the patient survive the night. And then we reach stage 4, generalized fecal peritonitis. Guys, this is a catastrophic, true emergency that requires immediate operative source control. In this scenario, resection of the perforated colon is strictly required. You absolutely have to remove the source of that ongoing fecal spill. And because the degree of contamination is just so massive, and the patient is usually in severe shock, an anastomosis is rarely, if ever, safe. So these patients are almost always managed with a Hartmann procedure to save their lives.
Okay, Section 3, our key clinical pearl, the critical distinction.
Right, so here is the absolute critical binary you need to memorize to distinguish those two most severe stages. Hinchey 3 equals pus. Hinchey 4 equals feces. Both are generalized peritonitis, sure, but that frank fecal contamination in stage 4 indicates a massive loss of structural integrity and a much more profound physiological insult. So on test day, if an exam question stem says purulent, I want you to immediately think 3. If you read faculent or feces, jump straight to 4, no hesitation.
Let's hit Section 4, the classic exam trap. Don't get caught.
I'm telling you, examiners absolutely love to distract you with modern CT-based modifications. Today's advanced imaging subdivides these stages into things like stage IA or IB, IA or IB, but here's the vital insider secret. The classic 4-stage Hinchey classification, that remains the essential, gold standard framework for standardized exams. Do not, under any circumstances, let a highly specific CT report in a question stem lure you away from those basic Roman numeral I through IV foundations. Don't fall for it.
Finally, Section 5. Quick recall test. Lock it in.
Okay, let's put this explainer to the test right now. A patient with perforated sigmoid diverticulitis has generalized peritonitis containing pus but no fecal contamination. What is the Hinchey stage? Take a second, focus on the specific type of contamination we just talked about, and lock in your answer.
All right, if you immediately thought of Hinchey third, you absolutely nailed it. Generalized peritonitis with pus but zero feces is the literal textbook definition of stage 3.
So before you walk into your exam or step onto the surgical floor, I want you to burn this exact anchor into your brain. Stage I is local. Stage 2 is a distant abscess. Stage 3 is pus. And stage 4 is feces. It's incredibly simple, right? But under pressure, this 4-point checklist is going to guide you straight to the right answer and the correct management plan every single time.
As you wrap up your revision today, I want to leave you with just one final thought. We know the classic 4 stages govern our exams right now, for sure. But as imaging technology continues to evolve, literally allowing us to see microperforations with pinpoint accuracy, how long until those hyper-detailed CT subdivisions completely rewrite the classic surgical rules we rely on today? Like, will the classic Hinchey classification eventually just become medical history? Keep that in mind next time you're on the wards. Thanks so much for joining me for this explainer, and hey, good luck with your revision.